So how can we change that and solve the problems the patient is facing? So that is our topic for today. It's a vast topic, and I usually take much longer to talk about it. So 45 minutes to 1 hour is not sufficient. But if you can even take 5 to 10 points that can make your life easy, then it is definitely worth it. Okay, so I'll try my level best to do that. Also, I would request you to post your questions and write them down in the chat or somewhere so that once I'm done, I can address them as well. All right. So before I begin, why is it hung up? Yeah. So I would like to introduce my daughter because I always do that. And the reason I show this photo is this is when she was almost 1 month old or 3 months, 1 to 3 months, somewhere in between. And the reason I show this photo is because if you can see, she needs dentures here, right? You can see the arch, it is edentulous, and I got super excited and I clicked that photo. And this is how she looks now. All mothers talk about their children, so please don't mind. I just usually introduce her. So any of you who've attended my lectures or workshops before have probably seen these photos. And after that, now one more thing which has been spoken about during the introduction is my book. So this was launched some time back, and it's a handbook on mostly for clinical procedures where you can see what to do in every step. So it is not like a textbook where we read everything and we can write an exam. It's not that. It's just that we read the procedure if the patient is coming in, and it's going to make our life a little easier. We'll know what to do. So that's the book. And okay. So during dental school, as I said, dentures is one thing which we have always, we've learned from the beginning, and still we've had some problems. So the main reason for that is that the patients are of a certain age, they are old. So those geriatric patients have medical issues. They are many times not very patient, and it's just difficult for them as well as you. Second is there is that you're putting a hard movable object, that is a denture made of metal, on top of a soft, soft compressible tissue. You have bone, you have soft tissue, and top of that you have a hard denture. So the core soft tissue kind of gets stuck in between and it hurts. So it is not similar to just doing a tooth preparation. It needs a little bit something more, and that is what we need to learn now. All right. So when a patient comes to us, what does he really want? Like, what do they say? No patient will come and say that, doctor, I want a CAD-CAM denture. It has never happened to me, and I do a lot of dentures. So no patient will come and say that I want Ivoclar teeth set, right? Because they don't know and they don't care. So what does the patient want? The first thing which they will, they'll tell you is that can I eat with it? Will I be able to eat with it? That is the most important thing. And then the second thing is aesthetics. Will I look nice? Like, why? Because just because they've lost their teeth does not mean that their social circle or their social life is gone. They need to still function and look nice and live a full life. So these are the two things the denture patients require from a dentist. Okay. And that is what we're going to fulfill. All right. So coming on to the topic, common post-insertion problems and their solution. Now there are, basically there are two, just a second, yeah. So there are three things which happen. First is when the denture is in our hands and the patient is sitting, the most important day, because we have seen the patient from primary impression, diagnostics, and then eventually, finally the denture is ready after so much of hard work by you, and the patient has come many times, right? So you're also excited and probably a little scared. Will it fit? Will it fall? That's the thing. So first is the immediate problems. The first day, the time when you put the denture in patient's mouth, the problems you face, they are the immediate problems. Second is delayed problems that, many times we tell the patient, it'll get adjusted. Don't worry, adjust ho jayega. And you go home and you're hoping that it gets adjusted. And the patient comes back after 2 days or one day, and then you ask, is it hurting you somewhere? Or the patient, can you eat with it? So the problem which patient faces after 24 to 48 hours is the delayed problem, okay? and kind of like an immediate delayed problem. And then the third is delayed, that is patient comes back to you after 6 months and more. For example, a broken denture, okay, or a fractured denture. So those problems we'll not be discussing today. We're going to discuss the immediate and immediate delayed problems, okay? All right. So now, what are the patient complaints? What does the patient come and tell us that this is happening? Patient will tell us about pain. Patient will tell us about loose dentures. He may say that, doctor, I know you've done a great job, but I just can't eat. Okay, that is the thing. Then there you have inability to chew, as I said. Sometimes patients complain of tongue or cheek bite. They say that it's fine, but when I'm eating, suddenly, I feel that my tongue comes in between or I have a cheek bite. Then we have the speech. When there are no teeth, patients somehow, manipulate their tongue and lips and cheek and try to speak in a certain way. And suddenly, if they get dentures, it all changes. So the speech also changes, and many patients cannot adapt to it very easily. So that is one point. Then we have food sticking to the dentures. I have patients who say, it's a great denture because they have seen you work hard. So they are being kind to you and me, and they say that it's a great denture, doctor, you've done a lot of hard work, but it's just that the food kind of fills up. It doesn't, I eat, but it just stays on my denture, it sticks to my denture. So that is something we're going to talk about. Then we have occlusal discrepancy, that is, you don't have even contacts, discomfort, numbness, heaviness, and finally the one which everyone hates and dreads, that is the gag reflex, right? If the patient feels like a gag reflex with an impression material inside the tray, the fingers, the gloves, everything, it is very traumatic, not just for the patient, even for the denture, because the saliva is flying everywhere. No one likes it. So yeah, that is something again we're going to talk about. All right. Now, what we're not going to discuss today is post-insertion aesthetics, because I'm assuming that all that has happened during trial. Patient's happy with how he looks. So that is not what we are discussing later, okay, in this webinar. All right. Now, the first thing, why do you get pain? First thing which patient, comes in, which you have to check, is that ulcers and inflammation in common areas. Where does most commonly ulcers happen? I'm going to take each one individually later. So first is the freni. We have to ensure that there's enough ample space for the freni to sit in the denture. Okay. Now, labial freni does not have any muscle in it. So we don't have to give like a big U shape for it to move. It does not move that much. It only goes up and down. The labial freni, I'll repeat, does not have any muscle. So the space which we need is very little. Okay. It's like a slit which you need for the labial freni. But for a buccal freni, there are muscle attachments there, and we actually need more space. So if you are the dentures in the patient's mouth, please ensure, and you feel it's not sitting too well or it's loose when the patient opens the mouth, check the freni. Usually it's the buccal freni because the muscle gets activated and we have just given one small ditch for the freni to sit in, but actually it needs more space during function. So check all the freni, okay? There should be ample space in your custom tray initially to record the freni. Once you record it, see, if you see these two impressions, the first impression with alginate, you can see there's enough space here. And then in the final, the space is a little less, right? So what happens when we are working, the freni, the space, the pressure we are applying, the material where it's flowing, so basically it keeps changing. So what actually we need and what we get in the end is very different, right? So it's best to just get it in the impression. If we don't get it, we should not, worry, and we should understand that for labial, you need less space. Check it, mark it, create it. For buccal, you need more space. So give a little, don't give just a V. Give like a U-ish appearance so that the muscle can sit inside. All right? Okay. Now, apart from the freni, where else do we get ulcers? So we get it on the surface, like on the ridge. And what do we check now? Why do we get it? So there are basically three reasons. One is that the denture in that area was sharp. When the denture comes from the lab, many times we don't really check the denture, right? It's just sitting there, and we wear our gloves because we're in a hurry and there's one more patient waiting. And we just take the denture and we put it in the patient's mouth. As soon as we do that, the patient goes like, oh, it's hurting. And then you're like, okay, It happens, don't worry. You take it out and then you actually see, is it sharp somewhere? So ideally see that before putting in the patient's mouth. It may be sharp in some areas, all right? Second is uneven pressure, because that is because sometimes because of occlusion discrepancy or the movement of the denture. And last is, as I said, the denture movement. So we're going to talk again about these. Now, if you see an ulcer, the patient has come back to you after 48 hours and you see an ulcer, you can easily spot that ulcer, right? The reddish, whitish thing which is there. How do we trim? How do we usually trim? Now, I don't, I prefer if I can talk to you directly and you can answer me. Now, but in a webinar, it gets very difficult. But the answer I usually get, which I have also done many times, is the ulcer. You put the denture and we see after, okay, it is below the first, below the premolar. You take out the denture and then you forget, was it under the first premolar or the junction of canine and first? It doesn't matter, let me trim the whole thing, it will get resolved somewhere. So that happens, but we should not do that, because the denture becomes unstable. So what we can do is we can somehow mark the ulcer in the patient's mouth, put the denture back, the dye which we have used to mark will get transferred on the denture, and then just trim only that part. So we will be very, very precise. Okay. Now, do I have to buy expensive things for that? So I know dentistry is expensive. I touch a thing and thousands go. It is so depressing. I get it. So you don't have to always buy expensive things. Buy things which you really, really need, and then work with it and make yourself better. So this, what I have shown here, is actually bio ink. It's a dye. It cost many years back. It costed me 1,500, and it does not get over. It's everlasting. But the point is that you don't have to buy it. What you can do is, if money is an issue, we can, or you're just a beginner, or you just don't want to spend on dentures, then you can use your Eucerin pencil with spirit. You remember, we could crush it, get that thing and put it there. If you're not doing too many dentures, but if you are doing too many dentures, then this is not a bad thing. It's a good thing to have in the clinic. But ensure that the surface where you're marking, there is no saliva. It's absolutely dry. Okay, because if the dye mixes with saliva, it will spread everywhere and you'll not really get any mark. So make sure everything is dry, clean it properly, and then use it. All right, now that was when we see an ulcer. Sometimes we see an ulcer in the vestibule. Sometimes we don't see an ulcer, but we see generalized redness. Okay, so what do we do in that area? We can use something called as a pressure indicating paste. How do we use it? There are a lot of companies which have it. We apply it everywhere. Okay. And the area where you see that the pressure indicating paste or the pip has come off the surface. Okay, I'll repeat myself. For example, let us say that one area is reddish, or you're just not sure of the balance of the denture. You apply this pressure indicating paste everywhere, put it in the patient's mouth, ask him or her to close tightly and talk, and after some time remove it. So the area where you see that the denture shows through the material, that is the area where the pressure is more. Okay. Now how do I change that pressure? Do I just trim it? No. First thing, to check the pressure, check the occlusion. Okay. Take an articulating paper, check is the occlusion equal on right and left, both sides. If you feel it is not, make the changes in the bite. After that, again check. And 90% of the cases, you will see that the pressure will become even. You don't really need to trim the denture. You just had to adjust the occlusion. But even if then also you feel that no, it's not working out, then you can take a burr and trim it a little bit. Okay. Once you have checked the occlusion or you have trimmed it depending on what the problem was, you will see that the pressure is equal everywhere. All right. Okay. Then, now these are small things. We know that there's an ulcer, there's an overextension. We can work around it. If you don't want to use, again, I'll repeat myself. If you don't have this pressure indicating paste, it's fine. You can use ZOE. It works the same way. The only difference is that it's a little messy. Okay, but again, you don't have to buy it. I generally don't tell people that buy a certain thing, because there are always things we can work with which are already there in the clinic. Okay, all right. Now, all these are small things, as I said. The most common complaint of a patient, denture patient, if you've done everything right according to you, would be that my mandibular denture hurts, okay, or it lifts. So coming to the first thing, that my mandibular denture hurts, we ask the patient, where does it hurt? And 90% of the times they will say that it hurts in the inside, on the inside of the denture, in the alveolingual sulcus, and it's or the lingual flange, right? So that is the most common. They tell you it's hurting inside, andar se dukh raha hai. And then what do we usually do? Let's say this is our patient, okay? If this is our patient and this is our ridge, what will be our first thought? We have made the denture, we put it in the patient's mouth, patient comes back and says, doctor, it's hurting me from the inside. Our first thought would be, maybe my alveolingual flange my lingual flange is overextended. That is the most common thought which goes through a dentist's mind. Because denture making is an arbitrary process. We don't have too many guidelines. We're not very sure what is where, okay? So, and things move. So because of that, if the patient comes and says, it's hurting me from the inside, don't just trim the denture. Don't reduce the flange height thinking that, oh, maybe it is overextended. It may be, but that should not be your first thought. Why? I'll tell you that now. Now, this is a patient of mine. Okay, I'll just show you this video. If you see in this, it's a lower denture and it's fairly retentive. Okay, it's not, retention is pretty all right. Now I'm going to just show you the ridge. Now this is a thin ridge, but more than that, issue is that there, you see this? Yeah. So if I see something like this and it's hurting the patient, I will think, oh, it's hurting because it's overextended, and I will end up trimming. Now, what will happen when I will trim the denture on the lingual flange? The denture will become short from there and I will lose the retention. Okay, so I'll repeat myself. If I see something like this and I have excellent retention and stability, but it hurts the patient from inside, and I reduce the height of the denture flange, my denture will become loose in most of the cases. If it is very, very overextended, then obviously we have to reduce. But in most of the cases, if everything is fine, it's hurting not because of the denture flange extension. What is the common problem? Why is it hurting? Okay. Where to trim or cut? We have to understand that. For that, we need to understand basic anatomy. All right. Now, this is a mandibular ridge. Okay. It is barely there, but it is one of my patients and it was fun working on her. The point is there are two areas in the mandibular, area inside, as we spoke about alveolingual areas. Now, it's the anterior and the posterior. Okay, first understand this. In the anterior area, you have geniohyoid muscle, which is a horizontal muscle. You cannot really press it down. In the anterior area inside, the geniohyoid muscle cannot be really pressed inside. There are, lot of things which can hurt the patient, like this area. Now, genial tubercles are there. If the ridge is very, very resorbed, then genial tubercles kind of come up, and then you can actually feel the spicules with your gloved finger, and geniohyoid muscle also. So you cannot really give a huge flange in this anterior area. So if the patient is saying it's hurting in the anterior, it's usually in this area because you don't have depth, and that is where you can reduce. But most commonly, it's not that area. Most commonly, it's posterior. So what is hurting really? It is not the flange extension, it is the mylohyoid ridge. Okay. Now mylohyoid ridge, as you can see in the photos, is present here, and it is in many patients it is very sharp. Now, if we have not given provision in our denture for the ridge to sit inside, as soon as the patient bites, he'll say there's no pain when I'm talking, but as soon as I start eating, what happens? The denture moves. Denture does not move just up and down, it moves laterally as well. When the denture moves and the ridge is sharp and there's not enough space there for the ridge to sit in, the tissue comes in between and it hurts. And that is the reason, and that is the place where it hurts. Reducing the height of the flange does not solve our problem. Okay, so what should we do? Ideally, when the patient has come, our impression should have enough space for mylohyoid ridge to sit in. Now you can see this circle which I have made. So we should have space there. Now let's say we tried our level best, and the space, the dentures, kind of ready, and the space is not there, or it's still hurting the patient. What can we do? We take this area, in this particular area, uh, we can trim the denture, like here. Take a burr, a denture burr, and trim this area. So what are we doing? We are creating a little concavity in this area, specifically so that once we create the concavity, there is space for the mylohyoid ridge to sit in. Now, if it, let's say we have done everything, in the impression also there's space, in the denture also there's space, but still it is hurting because the ridge is very sharp. Whatever you do, it is just very sharp. So what do? We can just mark that area in the flange and we reline it. If we can reline it with a soft reliner, when there's lateral movement, and it will press against the soft reline and not the hard denture. Okay, so these are the options or things that we can do. Reducing the height does not help in many cases. You just have to create space inside for the ridge to sit in, kind of create a concavity. All right. So this we have discussed. Now, other thing, where else does it hurt? Now, I'm going to discuss a case with you, because a lot of doctors have told me that how do you know where to stop in your dentures? Where should the custom tray stop? So I said, okay, it should be around 2/3 of the retromolar pad area. Now what happens is they're like, okay, but I can't really see the retromolar pad area. Where is it? And then we go like, okay, many times it's not possible to see that particular retromolar pad, but you have an idea that this is the general area where retromolar pad should be. Now this is a case, upper and lower photos you can see. Now these are the primary impressions, custom trays. Okay, I'll just go through fast, before, after. The reason I've shown you this case with basic impression materials like green stick, ZOE, and alginate, it's not because I don't use other things. I do use other things. I use functional impression materials as well. It's just that to show you that we can all do good work with simple basic materials if we understand what we are doing. So it's not the materials that are very important. They are good. If they are good, it's easier. But from basic things, we can get good results. So this is before, this is after. Okay. This is before, this is after. That's her. Okay. Now she came back. She said she was very happy with her dentures, and she's a very good patient. She's a lovely patient. It's been 2-3 years now. But when I gave her the denture, after 2 days, she came and she said, I'm eating everything, because some patients are just good. They can manage with everything. And she said everything is excellent, but it's just hurting in one area. So when I removed the lower denture, I saw that it was hurting in the, because if you see the retromolar pad area, it's not very visible in her ridge, on her ridge. So maybe it was a little overextended. So we reduce a little there. So how much should it be? In the retromolar pad, the fibers of the pterygomandibular raphe and superior constrictor from the sides and temporalis, everything gets attached to the upper 1/3 of the retromolar pad area, where the muscles attach. So obviously that if you cover with the denture during movement, that will give you pain. So either we create some space like this, like a ditch posteriorly for it, or else we keep our denture and our custom tray and everything to 2/3 to middle of the retromolar pad area, because that part is compressible. Okay, so this is the mistake I did here, which I'm showing you. And I trimmed it off. I've taken it down. There is absolutely no problem. There is no loss of retention, because if you are between 2/3, that 2/3, anywhere in that 2/3, you may be middle, you may be lower 1/3, that is all compressible, and that will create that suction and seal. The only thing you have to make sure is don't cover it completely. Okay. All right. What do I use to trim those? It's always preferable to use stones, because if the patient is coming back to you, most of the times we don't send the denture back for polishing. So if you're using burrs, you don't get a very smooth finish. So what I use is stones, and the one brown one is like a silicone buff, so that you can just smoothen it. It's just easier. All these things can be found easily on any trade fair. There's so many burrs, and we don't know why the guy is sitting with so many burrs. They are from there, so you can just buy that. All right, so this is before, after. Now, when I did this case, most of my cases are online or on Facebook, because it's fun, and I put it there. It's nice when people say nice things, and Also, you learn a lot when someone points out what you have not done well. So this is the case which I put on Facebook, and one of the colleagues, he said that, have you also done Botox for the patient? And it was really funny because I was like, no, I've not done Botox. She's just so happy that all her wrinkles and worries have kind of gone away. So this is the impact a good denture can do on the life of a geriatric patient, or make in the life of a geriatric patient. And that's why we are all here, because we can give back the life they deserve. Okay. All right. So this is her before, and this is her on the day of insertion. See, she's so happy, and seeing her, I became very happy. So she's pretty amazing. She's a very good patient. Okay, so this is then this is after 2 days when she had come, when she had that ulcer in the retromolar pad area, which I asked her to, which I trimmed when she said it's hurting. That was the after 2 days when she had come for her checkup. So retention and all, it's okay. We can all get it. The only thing is to know basics of every denture making. If we know the basics, we can work with any material and it's going to work in most of the cases. Obviously, there are some really bad cases where nothing works. So those cases are also there. All right. Now we've spoken a little bit about some problems. Pain inside in the lower denture, freni, other places. Now, the other most common thing is patients coming and saying that upper is fine, it is the lower which is giving me trouble. That is very common. See, someone will say, okay, upper denture does not give me any trouble. It's excellent. But doctor, my lower denture, as soon as I start eating, it just pops out, right? This is a very, very common complaint. Now, what should we do for that? First is to understand the basic anatomy, which I have been talking about from the beginning, that basic anatomy. I don't expect all of us to remember the muscles. It does not help us. We're not giving any exam. But we should at least know where the attachment is, how it is attached, so that we can work around it. Because if we don't know what kind of movement to do during bottom molding, or where to extend the denture till, then it's a problem. Okay. All right. So there are two muscles in the agrolingual area, sulcus area, where the patients have problems, and these are the two muscles which we need to understand. If we can understand the basics of this, lot of our problems will go, because majority of the problems are happen in the denture, and all that too also on the inside. So one is the geniohyoid, and the second one is the mylohyoid. Now geniohyoid, as you can see here, is attached. It's a horizontal muscle. It is attached like this and it goes straight. So you cannot really press it. But mylohyoid, which is on the posterior side, is a vertical muscle. That is, if you put your mirror or a finger inside the patient's mouth on the, in the posterior region of the agrolingual sulcus and just press, you'll feel that your finger keeps going down. You can actually, this whole area, you can go down. You can press and go down. So it's a vertical muscle. That is why overextensions are usually on the agrolingual flange not a problem. Because if you are 2 to 3 millimeters overextended, doesn't matter. It will still, it's a vertical muscle. It's not going to hurt. But if you are a little overextended in the anterior area inside, it's going to hurt, because geniohyoid is a horizontal muscle. You cannot press it. So try it in your patient's mouth once. See this, and then you will understand. Now, so agrolingual sulcus is basically this space between the residual ridge and the ridge, residual ridge, and you can see the whole thing. The main thing is, we all know what it is. It's just that we have to figure out how to work with it. Now, when we make a denture, or first, let's say we made an impression, many times we try to get that S shape. Okay. Now, especially on Facebook and other social media, if you get like a very, very pronounced S, you feel you'll get more likes and it's exciting. But the S, it depends on the patient's anatomy. If we ask the patient to take out the tongue during mandibular denture, mandibular impression making, if I tell the patient, okay, take out your tongue and move it, at both sides, and patient is not moving it within the oral cavity, which he should, he takes it out completely and he moves it outside. If they do that, what happens? It is not normal movement. When I'm talking or eating, you can't see my tongue. So asking the patient to take the tongue out and move it outside It does not make sense. So if we do that, or there are very, very exaggerated abnormal movements, then what happens? The flange, the muscles move too much, and the flange, alveolingual flange, gets shortened. Okay, so you will get a very, very pronounced S, but it will be short. Okay, so that's what something we don't need. Now, what happens if we have a short flange, that is underextended flange? The biggest problem is lack of stability and retention, and the denture will lift. That is one problem. Now, if we have an overextended denture, that we don't tell the patient to do anything, or the most common problem is that our custom tray is very, very big. Okay, if our custom tray is very big, then whatever impression we make, it's going to be overextended. So if that is the case, then what happens? Initially, when you press patient, you will get retention because you have pressed that posterior mylohyoid muscle. It has gone down a lot, much more than what it should, and you have retention for few seconds or a minute, and then as soon as the patient starts talking, it just lifts up. Why? Because we are not within the physiological limit of the patient's muscles, right? So this is the problem. So overextension and underextension are both problems, but we need to do the movements right. Okay, all right. Now, okay, it's so vague, what I'm saying. Don't do overextension, don't do underextension. There is no problem with overextension, just trim inside for the mylohyoid ridge. There's so much to know, and there's so much to really see in the patient. So how do I really know which area is giving me problem, right? Let's say your patient has come back and there is no retention in the lower denture. So how will you know what is the problem, right? Theoretically, it's easy for me to say that do this, do that. But for you as a clinician, the patient has come back and he says, doctor, my lower denture is loose. Okay. So you need to figure out which area of the denture is making it loose. So for that, we need to understand there are two types of retention. One is the border retention. That means that all the borders of the denture, except the area of the lingual flange, okay, give you retention. That is when you pick up the denture like this, it should not come out. That is a border retention, that all the borders are fine. You pick it up and the denture does not come out. Second is a tipping retention, which is for the alveolingual flange. That is, you tip the denture and that sound comes. Okay, so if let's say you tip it and the denture is retentive, but when you lift it, the denture is loose. So where is the problem? It's on the buccal and labial borders. But if let's say you pick it up, you pick the denture and it does not come out easily, but as soon as you tip it, it easily comes out. So where is the problem? It is in the alveolingual sulcus area. Now what I'm saying, I'll show you. Okay, how to check the tipping retention. Now this is a patient and this is the custom tray. What you see the metallic thing look, that is the tin foil. It is put by the technician so that the wax can easily come out, because I hate scraping that wax out. Other thing you can do is ask your technician to put a little bit of Vaseline before making the custom tray. Put the Vaseline on the wax before making the acrylic custom tray, so that when you can peel off the wax rather than scrape it with your cover. Okay. All right, so here it's a basic sectional impression where I have placed the material in the alveolingual sulcus. Now this material I have placed in the patient's mouth. Now if you can see, I will just show you, we do the tipping, right? And the tipping retention, there was retention just with this. It's not completely done, but still I had retention because that is a tipping retention. If I would have not, finished the borders, and if I couldn't pick it up, that means my borders are perfect. But tipping retention is only usually based, or what is responsible for it is the alveolingual flange. Okay, this is just the final impression of that. Now, lifting of denture or tongue bite. Why does that happen? Obviously, all these problems are intermingled. One reason can cause 10 things and other things can cause, other things. So one thing which we have to understand is that in an edentulous patient, the tongue is huge, right? Patient opens the mouth and the only thing you see is the tongue, and it is sitting on the ridge also many times. So the tongue is really, really huge. So in such cases, even if you've done the best of work, many times the patient pushes the denture out, or we feel that there's not enough space for the tongue to sit in, because the tongue has become so huge, right? So what should be done for that? Now, this is something I found in an article long back, and now it is part of, it's in the new voucher, it is there, I think. I checked recently. But why have I put it here? See, it's common sense. If we actually put our tongue inside like this and check the alveolingual area, it's not convex, right? It is not even straight. There's a concavity there. Okay. Now, I wouldn't ask you to put your finger and check, but when no one's there, you can do that. When you check inside in the alveolingual area, you'll see that it's not concave, it's not convex, or it is not straight. There's a ditch there. It's like a convexity there. But when the technician many times gives us a denture, he makes the wax rim straight, right? So the denture, it's like you have the borders and you have teeth on top, and the middle part where the acrylic is, it's absolutely straight. There is no space for the tongue to sit in. So what you can see here is a little concavity which is there. If we can create it in our dentures with patients with huge tongue, then the tongue will kind of, part of the tongue will sit inside and the denture will not lift. Please pay attention on this, because this has really helped me in making good dentures. Okay. All right. So I'm going to just show you another picture so that you get an idea. See, if the tongue is huge and we create a little concavity in the inside on the denture flange, okay, on the lingual denture flange, then the lower part of the tongue will kind of sit inside that slight concavity which has been made. The concavity cannot be too big. If it is too big then and creates an undercut, then every time the patient will lift the tongue, the denture will lift up. So if you go back, on top there is nothing, it's flat, and then there's a slight concavities for the tongue to sit in. Do not make an undercut. It is a very subtle, smooth concavity. All right. Okay. All right. Other thing, okay, again, some patients come and say that, okay, everything is perfect, but every time I'm chewing something hard or chewing more, then the denture lifts from one side, or, from behind. And so what we need to see is also look for something called as a masseteric notch. So what is a masseteric notch? It's basically, see, it's basically the buccinator gets activated, pushes the masseteric muscle, and that is how there's a small ditch which is created in the distobuccal area of the mandible, and that is the masseteric notch. Now, what happens there is when we are doing border molding, okay, because it all has to be taken care of in border molding. Therefore, denture making is slightly difficult because each and every step is important, right? We cannot say that let me finish it today and the final will become amazing. It doesn't work like that. We screw up one part and the whole denture fails, and that is why we have to be a little meticulous and slow. I basically am a slow dentist and I don't feel bad about it, because if I'm in a hurry, I usually spoil things and I hate to repeat anything I'm doing. So it's best is if I get it in first shot, because if I have to repeat it, I'm sure I'll not do a good job. So I'm slow, and I feel in denture making that truly helps. Okay. And patients are old, so it's best to have a little bit, extra time, 15-20 minutes extra for them, because they like to talk. And that's how the trust happens and you get better results. Okay, so coming back to this, when we are doing border molding, there are a lot of, now I'm not going to start on border molding lecture, but masseteric notch is important because, and so I'm going to just tell you this, whenever you're done with your movements of the mandibular border molding, place the fingers, okay, on the custom tray. And when you are placing the border molding material, green stick, or you're doing a single shot, whatever you're using, when you have placed it, okay, the distobuccal area, in the end, when you're finishing everything, the tongue movements and open, close, and other things, ask the patient to close the mouth. So you apply pressure, kind of push the lower jaw down, and ask the patient to close the mouth. So what is happening here is you are applying pressure down and patient is applying pressure up. Okay. So these two things are happening. Why is it important? Because this is what happens when the patient eats. For example, let's say the patient wants to have a cashew. Okay. I like cashews, so I'll use the example of cashew. All right. So the patient has a cashew and he puts it on one side. Now cashew is the food bolus, which is big. So when the patient tries to chew, what happens? The jaw closes and the cashew is hard. So it's going to apply the pressure. It will stop the jaw from closing. So that's what you are trying to get, the movement or the function, the eating, replicating the eating motion of the patient during the bottom molding. So I'm going to repeat myself again. I'm repeating a lot of things again, I realized, just because I can't really see everyone. So I'm just hoping that whatever I'm saying is making sense and is going to help you in the future. All right. So we need to duplicate or replicate the eating motion of the patient. Okay. So how do we do that? When the patient eats something, it's a hard food bolus or cashew, whatever patient is eating. Okay, the patient's jaw closes because he's trying to chew. Okay, close, and that hard thing is not allowing it to close till it becomes softer, right? So how do we replicate that? We put our finger in the patient's mouth on the custom tray, and we tell the patient to close the mouth. So patient tries to close the mouth, and with our finger we push the jaw down. We are acting the or replicating the movement of eating. So what happens? Your masseteric muscle, your buccinator, they get activated, and you get something like a masseteric notch. That is very important because it ensures that you get that notch. If you get that notch, it is not going to push the denture away. Okay, it helps. So we have to do it in bottom molding, and if we have not done it and the patient has come back, just mark that area, put a little bit of pressure indicating paste in that area, then do that movement. You will see the area where the paste has just removed from that area because the muscle got activated. Take a burr and create that space. Don't do it arbitrarily. Okay, just check it with something and then do it. Okay, now is retention always possible in all cases? Because we are not magicians. If there is no ridge and there is no alveolingual sulcus, and we can get it many times when you have good alveolingual sulcus but no ridge, that works. But nothing is there. So what do we do? Do we can we still give retention? So many times it is possible that we don't get that suction sound and amazing retention which we are hoping. But what in such cases where we cannot achieve it and we have a choice between retention and stability, then we should always choose stability. What does it really mean? Retention means that when you're trying to remove the denture, in layman terms, it does not come out easily. Stability means when the patient is talking, eating, all the movements they're doing, the denture is not really coming out or lifting, in spite of not having suction. Okay, so the horizontal movement of the denture, side to side movement, that is happening a little bit, but it's not, the denture is not really popping out in spite of not having that suction or retention. So whenever there's a choice, we will always go in for stability because the denture, everything should be within the physiological limits of the patient's musculature, and then retention. Okay, so an overextended denture, whether you're getting amazing retention, does not work. It's going to hurt the patient. It's going to come out on its own. There are a lot of things which will go wrong. But a slightly underextended, I'm not saying make underextended impressions, but I have noticed that a little underextension will still be tolerated by the patient, but an overextension will not be tolerated. So if you have to err towards something, err towards underextension. Okay. Now this is my patient. She has dentures. You can see the VD is low. Now she did not have any, she had horrible, absolutely nothing as a ridge. And that is why I gave her a little less VD, because if you keep increasing the height, the VD keeps going more, then it's a problem. Because then what will happen? The denture will easily come off. So in patients with resorbed ridge, it is best to reduce the VD a little bit. Now you see how easily it has come out, the denture. And when you see there is no ridge. But when she was talking, there was absolutely no problem. She could talk with it. She can open her mouth wide, but there is no suction. Okay. So it is possible, because if there's nothing, then you just work with what you have. Choose stability over retention. Okay. Okay. Now, we have spoken a lot about lower denture because most of the time when I'm talking to colleagues, everyone says that upper is fine. It's the lower that gives me trouble. But there are times when the upper gives us trouble as well. So we can't really completely skip it. So for sometimes, this happens that the dentures come, we place the upper maxillary arch in the denture in the patient's mouth, and tuck, it falls down. That is so depressing, right? Yeah, because we were expecting that we'll have some problem in the lower, but maxillary I'll manage. So if the maxillary actually is loose, it is absolutely terrifying, right? Okay. So you can tell the patient both don't fit. Okay. So what is the reason if something like that happens? One is a definite overextension, because I told you about the buccal freni, there's not enough space. Please check the space for buccal freni, lingual freni. Mostly buccal freni is what gives trouble. Okay. Second, as I said, overextension can also be on the distobuccal area, because when we are making an impression, we many times, we are working and the patient's mouth is wide open, which is a mistake. Whenever we put the custom tray in the patient's mouth, ask the patient to close the mouth halfway, like a semi-closed mouth. Because whenever we are putting the custom tray, patient opens the mouth very wide, because maybe this patient's first experience, or they're scared and a huge tray is going in their mouth. But what happens with that when they're doing bottom molding? It's not normal for a person to sit with mouth open that wide, right? It doesn't happen. Most of the time, our mouth is open for eating also, semi-closed position or semi-open position. So in what happens in distobuccal area, there's less space. If the patient opens the mouth too wide and you put a finger there, you'll see there's no space for material. So you put the custom tray with the material, ask the patient to close the mouth, tell him thoda sa muh band kariye, semi-close it, and then do your bottom molding, so that you have enough space in the distobuccal area and you ensure that your denture is not underextended there. Okay. All right, so these are basic things. The other thing which, if you're talking about maxillary, we have to talk about the PPS, right? Posterior palatal seal. Now, it has two parts to it. You have an anterior vibrating line and a posterior vibrating line. See, there's a lot of things which are there, which you can see in the patient's mouth. But let's be honest, there are very few people who actually take a pencil and mark the PPS in the patient's mouth. It's the right way to do, but there are very few people who actually do that, and the patient is uncomfortable because the patient is gagging and you are kind of drawing on the patient's palate. So if you can manage it, nothing like it. If you feel it's not your cup of tea and you cannot manage it, then understand something basic. Okay, what do I want you to understand? When your patient has come to you for bottom molding, you have already made the alginate impression, or you have used any other material like compound for an impression. What you are supposed to do is, you should know, your custom tray should end where your final denture will end. If you know that, that is your posterior vibrating line, right? You cannot go beyond that. So anterior vibrating line, you really don't need to know. What you need to know is where your denture will end. So how do I know it? Now, there you understand the basic thing. You have a maxillary tuberosity, you have a hamular notch, right? Now, you can see here, there is this maxillary tuberosity. You have a notch here called the hamular notch, and then you have the pterygomandibular raphe. Now, if you draw a straight line from hamular notch to hamular notch, that is kind of like a vague idea it gives you that my denture should be somewhere here, because it is not possible to have a denture which goes beyond this line, right? Because the patient will gag. It is not possible. Your denture must end here or shorter than this. It cannot be beyond this, right? So if you have marked it in your cast where the custom tray is made and you have trimmed it off in your custom tray, when you make your impressions, you cut it off in your final impression, your technician will know where he should end the denture. So in most of the cases, the PPS, will not, the material, the PPS will not be overextended, the denture will not be overextended, and your upper denture will not fall, right? So this is a very common problem, because what happens is that we get excellent retention during our final impression, and we think, oh God, let me not cut, because if I cut a little bit of material, what if I lose my suction and retention? We send this whole thing without cutting the excess to the technician. Technician thinks my dentist is so good. If I cut a little bit, what if I'm cutting something which he doesn't want me to cut? So basically, neither the dentist cuts it nor the technician cuts it too well. He kind of cuts a little bit and rounds it off because he's not sure where to end. You are the dentist, you have to decide where your denture will end. So if you can mark that line and cut off the impression from there and send it to your technician will end there. Okay? And that's how you will ensure that your denture is not overextended. Because it cannot go in the throat. If it does not help. Okay. Other thing that happens is rocking of maxillary denture. Sometimes we have done everything, it's amazing, but the denture, when you put it, you kind of feel it's not stable upper denture. That happens when we have made the impression and there are voids, right? It happens we've done the bottom molding, we are doing the final impression with whatever material we are using. That's not what we are discussing today. And there's a huge void in the center, right? Very common. And what do? We do something called as jugaad. We fill wax. I'm not against jugaad at all, but the issue is that we should know where we can do it. Now, if it is on the side, idhar udhar, it's fine. You can add a little bit of wax, or you can add a little bit of material. The issue is if it is in the area of the center, that is something which you need, because that part has to be perfect. If it is not perfect, you will have the rocking, because this wax in the center will cause the rocking. All right. Now, either that, or else if there's a very, very prominent midline raphe, then what you do is you give an extra spacer there. If you give that extra spacer there, it will not rock. Now let us say our denture is ready. It has come to our hands and it is rocking. Now I cannot go back the steps I have done. My denture is in my hands and it is rocking a little bit. So what you do is, that means there's not enough space for the midline raphe. What you do, take a burr, just put some material like ZOE or pressure indicating paste and put it in the mouth and press. If that is the problem, the midline raphe, which it is usually in rocking cases, you will see that from the material will just go from there. Okay, because it was more like the denture is pushing that midline raphe. Take a burr and just create some space. If you create some space, denture will stop rocking. Okay, this I'm not talking about the occlusion. I'm just talking about just the maxillary denture. All right. Food sticking to the polished surface. Now, what happens earlier? We used to think that like in the like as I told you, you have to give a little bit of space or concavity in the lingual flange for the tongue to sit in, but it's opposite in the buccal flange. Most of the times we have to keep it either flat or a little convex. If we create a concavity in the buccal flange, food sits. Many times technicians get overexcited, and what they do is from the teeth to the base, where the to the base, it's rather than keeping it straight, they think they are giving a better anatomy. They give a anatomy which we have, okay, and it sits like this, and then that depression the food sits. So it's best to just have a little convexity there, because buccinator middle and lower fibers basically are not strong enough to firmly press against that area, and that is where the food settles. So if you give a little bit of convexity there, you're helping the muscles to push the food out. Okay, so that helps. All right. Now, speech. What is the most common thing when the patient, what do we tell the patient to say? So every state in our country will say different things, but in our college, the most common things which we used to say, what we'd say 1 to 10, and when they are going to say 6 and 7, we are listening. So the patient is like 1, 2, 3, 4, 5, 6, and we're like, say it again, 6, and then the other words like Mississippi. Okay, and if you're, depends on where you're studying, you go like Sushila and things like that. Thing is, we are trying to gauge the S's, right? Why? Because what happens in this is, see, everything we have changed. Patient did not have teeth and suddenly we've given a full set. Now all the syllables, all the words are, the air passes through the teeth and lips and cheeks, and that is how you get the words. So very common is for new denture patients is to mispronounce the S's or the sibilant sounds. What happens now, if you see carefully, you can, again, I'm not with you there directly, but you can try. You just say S and see what happens. If you say S, S. So what happens is your lower edge, incisal edge, comes very close to your maxillary upper incisal edge. So rather than being like when you say S, it comes like this, but it does not touch. Okay. Now, so that is what you need. And if that is a problem, that is where the sounds go wrong. So if you, let's say you try saying S with your mouth a little open, so that space has to be just 2 millimeters. It cannot, or lesser, but it cannot be very big, or the teeth cannot be touching. If you say S with your mouth open, it's like esh. Okay, that is a problem. If you say with your teeth touching, S, esh, it's not normal. So the same thing happens with the denture patients. So what you need to check is, you check, is the tooth touching? Many times rather, the S's, the teeth are touching. So what we do is we just take a burr and just sandpaper it and just remove it a little, create some space. And you'll see that suddenly the sixes will sound like sixes and sevens will sound like sevens. Other thing is, if, so that is something which we can check, because most of the time the teeth are very close or touching, and that is the problem. So you create some space there. If you feel the space is too much, then we don't have a choice but to either add composite on top of it or change the teeth there. All right, now everything is done, we've checked, everything is okay, but the teeth don't fit. The dentures come, you place it in the patient's mouth, and we check and we see that the bite is not perfect. So most commonly it's the second molar which is giving trouble, but it can be anything, but it's most commonly it's the second molar. So what to cut? So it's very common for people to just remove or grind off the cusp. Okay, but if you do that, see, the efficiency of a denture patient is very, very, very low already compared to a person with normal teeth set, right? Like, I mean, with normal teeth. So a person who's edentulous, efficiency is low. And if you're going to just cut off the cusp tips also, then obviously it will become worse. So best is to, confine your reductions to cuspal inclines, central fossas, and marginal ridges. Okay. Now, where to trim? So you have an articulating paper. There are different thicknesses that come for dentures, because the denture is sitting on a movable tissue. If you're using like a 12 micron, it doesn't really help, because so much the tissue will move, right? So you need like 100 micron. You put it in the patient's mouth and check for the heavy premature contacts. So don't trim the mark, which is, let's say, using a blue marker. So don't use the trim the mark which is completely blue. Why? Because what happens, there's enough space that the whole die is still sitting there. Trim the part where you get something like a bullseye, as in the photo, that there's a ring of die around it, but the center is clear, like the center, you can see the tooth, because the contact was so strong that there's not even space for the die to sit in. So that is the problem. So removing the full blues and full reds does not help. Remove the bullseye, remove that part where there is no mark and there's a ring around it. The same thing you can do in your composites also. Okay, the same thing. All right. Now, discomfort, numbness, heaviness. Now, we have to ensure that there is enough space for the incisive papilla and metal foramen. Wherever the nerves and vessels pass, we should have enough space. So that means we give, if it's more prominent, give a double spacer or more. Or when we are many times doing bottom molding and with green stick, we keep dipping our custom tray with wax in hot water. So what happens in the palatal area and incisor papilla area, many times the wax is not there by the time we are done with bottom molding. So those areas give trouble later. So we have to be very, very mindful of that. All right. Now, last but not the least is gag issues. Now, you cannot completely remove it as soon as you're done, because we know those patients who have gag issues. It starts with the first impression. We make an impression and the patient is gagging, and the impression material with the trays in the patient's mouth, and patient is gagging, and you're thinking, should I remove it or let it happen, because she's not going to allow me to do it again. So it's a very interesting time. But small things which work in impression making, I'm not discuss how to make impressions in such patients, because that is a different thing and I don't have too much time. There's so much to tell, I want to discuss so much. The thing is that if we are giving the denture to the patient, and a patient we know has a problem with gag, there is the most important thing is to not have the palatal surface very, very polished. Like, I have noticed that, and it's written in books as well, is that if the palatal surface of a denture is absolutely polished, like buff to mirror image, and a patient is a gagger, his gag will increase, and he will tell you, I cannot wear the denture because the tongue keeps slipping. So what is the other choice we have is best to replicate the rugae. If you cannot do that, your denture is already ready and patient is not wearing, ask the patient to wear the denture for just short durations, only while talking. Dheere dheere, slowly, when they get used to it, they can increase. But I know this, you've not done anything. What if it's not helping? So what you can do is take a sandpaper and roughen the palatal surface. Tell the patient to keep the tongue on the rough surface. So what happens? Patient's tongue is forward on the palate, which is rough. It does not slip, and patient feels comfortable. Okay, so I'll repeat myself. If the patient is a known gagger and you are aware, try to give Ruge to that patient for the tongue to feel normal and sit on it. But if you don't want to do that also, what you can do is ensure that the palatal surface of the maculi denture is not buffed to a mirror finish, and it should not be so smooth that the tongue is slipping. You just take a sandpaper and roughen it. Roughen does not mean it's abraded and bad and all. It just means that it is not buffed. It is just sandpapered. So what happens? The patient keeps the tongue there. Tell them to keep the tongue on the rough surface, and you'll see the gag will slowly reduce. So that has really helped me. All right, so I'm done now. In time, I think it's almost 1 hour. So I can take some questions now. I'll stop screen sharing. And if there are any questions, do let me know. Thank you.
Thank you, Dr. Shivanki. Participants, if you have any questions, please type in a chat box. I think till now, no questions. Everyone understood everything, I think.
It just means no one understood anything.
That's
that
no.
Okay. All right.
1 second, I'll check.
So I'm here for another 5 minutes. If anyone has questions, till then, what I can do is I can just talk a little bit about my failures, because you learn maximum from failures. So if you guys are here, then I'll just show you. Can I just show screen again for 2-3 minutes?
Yes, you can.
Yeah. Okay. So I'll just show you that, because this is my longest failure. So I think it's here somewhere. Just a second. Okay, so this is, as there are no questions and we have time, I think I can just show you how bad the times when, we have failed. And obviously this is the failure which is pretty, and that is why I'm showing you. No one wants to show actually that how bad you can be. So it's patient is okay, but she's not absolutely happy, and she's been with me for a long time because it was a very tough case. But it's all right. Now I'm actually looking at, thinking of some kind of implants for her, but I'm not sure how, because it's just tough. So I'll show you. So this is a case. This is how she had come to me, and this is what we finished. She's very old. She's gone through laryngectomy, so speaking is difficult for her. But the best thing is that she's one of the very rare patients in the world who can talk without a voice box. She does not have a machine in her throat, but she has trained her other muscles to make sounds and talk. So you can actually understand her very clearly when she's talking. But you have to listen. It's like that. And she's very happy that she doesn't have to use a metallic voice. So she's a force in herself. Okay. So she's the patient, and she came to me initially with RPD. She was wearing an acrylic flipper, and she was very, very scared of losing all her teeth. So this is the case, and this is how she came to me. And she was referred, so I wasn't even sure what to do with her. And she said, can you make dentures for me? So she was wearing an RPD which was hanging to those lower 3 teeth. Okay. And upper she had an RPD she was happy with. She said, I don't want you to touch my upper RPD, just can you make something for the lower? And I said, I can try, but I'm not really sure what I can build here, because you don't have any alveolar sulcus, and there is absolutely nothing, there's no sulcus and there's no ridge, and she cannot really recline, there are a lot of issues with her. Like, okay, and I'm used to sitting and working, that is another problem. So what we did, we said we'll give it a try, because she was a referred patient. So thankfully money was not an issue. I said we can try. We did something like a functional impression for her, like a kind of, apart from functional impression, we also tried something like a modified neutral zone, and we could achieve something. The point is, this is a pre-existing FPD, this is a denture, and you can also see one natural tooth, which is the canine. Now she went back and I said, can you eat? And I also relined the denture because there was nothing else I could do to make it softer. So she said, it's fine, I can have idli. And I was like, you should be able to eat other things. She's like, yeah, I can manage toast also from front teeth. So I said, but can you have anything else? And she loves parathas. And she said, no, I can't chew parathas. It is difficult. My denture comes out. But I had to live with it. I said, "Okay, I can't do anything else." So after 6 months, she came back and there was pain in under her bridge. And she was very scared that I'll remove all her teeth. But the issue is I had to, because when I removed her bridge, the premolar was completely gone and everything was shaking. There was not much. So what we did, she said, I cannot be without teeth. And so we planned an immediate denture for her. And within 2 days, we made the denture, and we did the extractions on the same day the denture was delivered. We relined the dentures, and this is her upper denture. Now you can easily see that it's not a very nice looking denture. So that's because there was no proper trial, because her teeth were there. So somehow, and it was, hurting her. So we somehow finished everything and she was fine. Because, dentists look at teeth with a lot of love and affection, but patients look at teeth as teeth. They're white, they look like teeth, it's fine. So she was okay. She went back. Then she was very happy for a while, and then after 6 months, obviously, I had told her we'll repeat her denture after 6 months. So the bridge resorbed and a lot of things happened. So she said, I'm happy with your work, but because you are trying so hard, she could see how hard I was trying. She said that denture patients really appreciate you, no one else does. So she said that I want whiter teeth, and she showed me her photos, and she said I want gaps in my teeth, in my denture teeth, because I always had gaps. So the point is that it's a big success somewhere when you feel that the patient wants to look better, and she has faith in you that you can do something about it. So she came back. We did her impressions. This is functional impression called Data Seal function from DTAX, along with that Honegin light body. Then this is the upper. This is a maxillary denture. Now this is a lower denture. Now you can see the lower denture. This I have roughened it. What I have done here, this is part of the relining. What I do, you can see there are three parts like a tripod where there are lines marked. Okay, you can see on the corner also. So when I trim everything, you can see that three parts of the tripod are not trimmed because I don't want to change the VD. Rest of it I trim, and where then I reline. Now, what I've used here is a Tokuyama chair-side soft reline. The company claims that it's going to work for 2 years or more, but in my hands, at least Tokuyama is the best for relining right now, and it works for around 1 to 1.5 years, maximum 1.5, but sometimes one or lesser also, because it depends on the patient's chewing abilities and how they keep it. Now we gave spaces to her, so she was fine. She wanted spaces, so in the denture I made it. I didn't ask my technician, because if I asked my technician, "Uske daanton mein jagah de do, give spaces," he would be in shock, because technicians like to make all the dentures the same way. All dentures should look the same. You cannot even make out whose denture is, it's a female or a male. They all look the same. So I kind of disked it, but my technician is very sweet. He understands. But this patient I did on my own. So this is our journey with her. And in 2019, she came back again after 5 years. And so I realized, she said, my denture doesn't fit again. And I have made it already 3 times. And I was like, in 5 years. So when she came back, she said, you make it again. So I saw her and I said, yeah, you've undergone a lot of resorption from before. Because if you remember, what we had earlier and what we have now is very different. So this is her last tree line, which I did, which I kept on repeating for her. So it didn't fit anymore. She said, you make a new one for me. So this is her ridge now. So this is in 2019. So you can see that there is literally no ridge. It's become smaller than what it was. And this is what it is. So we made the denture, and I did not repeat the upper. I only did the lower again. So upper she was fine with. So I made an impression of the upper. And when I was doing the jaw relation for the bite, I flowed a little bit of aloo wax on top, because modeling wax moves. So if you have aloo wax, it's a small tip that you can just flow the aloo wax. So the technician will know exactly where the teeth are. It really helps. Okay. And this is the lower reline denture. It's looking much thinner than last time because she's lost more bone. And this is August 2019. Now, she is actually, now I saw her recently. She had fallen down and her dentures again broken. and the upper is also broken, and she has a major cut. So her incisive papilla is kind of cut in two. So if you see, there's an anatomical problem now. So I have told her, let's try to fit an implant somewhere. I don't know how I will do it. I've been speaking to my surgeon. So once COVID goes and she's more comfortable, probably I'll have more of this case to show you, because this is my longest failure case. So it should be fine. So I think I'm done now. So if you have any questions,
Yeah, actually 2-3 questions are there in the chat box.
I'll just check.
We'll see. One second.
Okay.
From Dr. Prachi, ma'am, can you please give me a quick revision for post-inserting lower denture, less retention?
Revision, seriously, revision.
Uh,
Post
actually,
insertion.
actually, if you want a revision, this is actually live streamed, so you can go to YouTube link. We'll send you the YouTube link so that they can actually
Right. So Dr.
for
Vijita
24 hours it will be there.
yeah. So basically, IDA coaching, they are so well prepared. They have it's there for a day. They asked me, and the whole presentation is present. It's like a small, thing in a big thing, but end of the day, small things can make our lives easier. So it's there for 24 hours on YouTube. You can connect with the organizers and just go to their channel, I think, wherever it is, and you can re-hear and re-see everything again. So don't worry about that. For the revision, it's there. So the next question, I get suction during lifting while, this is Dr. Sujit. I get suction during lifting while doing border molding, but during insertion it is lost. Right. So I had, if you remember, it's also part of the revision. You'll see that I had written that when we are doing border moldings, many times we feel that the denture, the suction and retention is amazing. But when the final denture comes, you feel the patient opens the mouth and the denture lifts, okay, or it's loose. So that happens many times when the denture is overextended, because what happens, your custom tray is bigger than what it should be, and the material, obviously if the custom tray is big, the material will be more. But when you press it, what happens is the tissue is mobile, right? Especially the sulcus, and the alveolingual sulcus posteriorly is very mobile, because the mylohyoid is a vertical muscle. So what happens when you are pressing it, it keeps going down. So if your custom tray in the alveolingual sulcus is very, very big, and you put material and you press it, you get excellent suction, because everything is pushed to its limit. But when the final denture comes, you place it for a second. If you press it, you will still get retention. But as soon as you leave it, within a few seconds, the denture will come out. So that is what happens. So in such cases, maybe I feel that your custom tray is a little overextended. So if you can check your custom trays better, your retention should not go away. Okay, so try that. Then I have Dr. Sanhita. In patients with resorb ridge, how often do we need to change the denture or reline it? Okay, so see, by the book, in 3 to 5 years of time, every denture should be changed. Like 5 years, you should change a denture. But in India, it does not happen, right? Because our country is very cost effective. And what happens that if some patient gets used to a denture, it's like their body part. They don't want to change it ever. So I have patients with 30, 40 years of denture wearing also. It's very interesting. I don't know how they are eating. So it's amazing. The point is 3 to 5 years. In a resorb bridge case, we need to change it. But as patients don't agree, we have relined it, okay? Especially soft relining, if you have done, you might have to change it once in a year, the relining, soft relining. But if you want to do a hard relining, like proper border molding and then final impression, then you need to be very, very careful, because what happens, the acrylic teeth, if you are not using the expensive Ivoclar teeth and other things, we are using regular Acry Rock and all, in few years they will attreat. Okay, the patients, what happens when the teeth are retreating, this is the jaw, and when the teeth are retreating, the patient will start eating from front teeth, so the jaw will come forward like this, so it becomes like a pseudo class 3. So if we are thinking, patient says, no, I want to keep the same dentures, can you improve the fit, and the BD is lost, the centric is lost, and we just reline it, then we are kind of helping the patient go in the wrong direction. So if you are relining it, you have to ensure that the patient's VD and centric and the condition of the denture is perfect. If you are not sure of it, convince the patient that you have to change it. Okay, do not try to reline it, because everything is wrong. except the fitting surface. It doesn't help too much, right? Patient will have angular cheilitis and a lot of other things which they don't realize the problems which we have to tell them. Okay, all right. I must have made good number of dentures from mill to conventional and single day denture. Don't you think? Denture, dentist specialist. I can't see this. Just a second. Don't you think dentures and denture cost the fee are all fake? And a success is by the best person who is fake. I don't get the question actually, because the best denture is with which the patient can eat and has no complaints. Now you or me or anyone can see and feel that this is not a maybe this is not a good denture or this is the best denture, and still patient is complaining. Sometimes patients complain, say that I doctor, I can't eat, but you check and you see that it's actually very nice. You don't find any problem, and the patient, no, I can't eat. It's not that great. And there are some patients that I had a patient once. The denture was broken in three parts, and the patient was comfortably juggling and eating. I said, how do you manage it? And she's like, yeah, it broke during COVID time. I didn't want to come. Now I've gotten used to it, but I want a new denture because it's broken. But I can eat everything. So you have people like that. So it's like who's who's a fake, who's not. It's very, very varied, and I don't think there's any answer to it. But thank you for your question. All right, Miss Dr. Menon, ma'am, up to how much we can reduce the VD in resorb ridge? See, again, it depends on the patient's vertical at rest, right? You ideally, by the book, you go VD at occlusion, you go 2 to 3 or 2 to 4 millimeter lower. But what I have seen is that if the patient's ridge is resorbed and you give like a, from rest, you give a normal 3 to 4 millimeter lower, then it's still very much away. The denture, the teeth are very much away from the ridge because the ridge is very, very resorbed, right? So there is no hard and fast rule that you can go 5, you can go 6, you can go 7. There's no hard and fast rule. That is a decision which, while doing the vertical, you will have to take, seeing the patient's musculature and how the patient is, and accordingly decide. There is nothing in the books about it, but I just feel that a little lower helps. So little lower is vague, I know, but then little lower means probably 2 to 3 millimeters more than what you would have done. That helps, okay? Because you cannot make it very low, because then the lip will go inside. Can't do all that. So this will droop. So you'll have to kind of figure out that on your own. Dr. Prachi, how to decide that when do we have to do relining or rebasing or make a new denture? So this is something I've already spoken a little bit about. See, what happens is that if a patient, let's say it's a denture which everything is fine, the patient has got a good quality denture made, the materials used are the best, so obviously the attrition will be lower, especially if the patients are upper and lower, both are dentures. So if the attrition is lower, you feel the denture is fine, but there is some resorption where you can everything BD centric is almost okay, and the patient can make do with for a couple of more years or some more time with the same denture, but just if the fit can improve. So those patients, you can reline. Rebasing, personally, I don't recommend and I don't do, because I just feel it is easier and better results you get with just making a new denture. So, and in India especially, most of the times the teeth are not in the best of condition after a couple of years. So it's best to just remake it. Okay. Thank you, ma'am. Thank you, Dr. Ramesh. Okay. Thank you.
Almost, I think.
I think they are done now.
Yes,
I'm not sure if I missed anyone, but
no, all questions you have answered actually.
okay.
Nothing
So
left.
before I end, I would just like to thank everyone. Okay, there is a question, Dr. Sanhita. As we have different types of teeth sets, so in brief, can you tell us which type of case should we use? For example, 0-degree teeth. Okay, so doctor, this is actually I've not covered in this because it's not part of this particular. Uh, this particular lecture, because I just had 1 hour in which I had to cover only post-insertion problems, but I understand your question. So I'll tell you with personal experience, I don't use 0-degree teeth, because what happens is already the efficiency of a denture patient is very low. So if you are using 0-degree teeth, see again, 0-degree and monoplane, they are two different types of teeth. 0-degree teeth are where there is no anatomy at all. But if you see, if you can go to the textbook and check monoplane teeth, basically they are flat. but from their flatness also they have some anatomy. It is just that they don't have any cuspal inclination, but rest of it, they have four cusps, they have some anatomy. So if you feel that it's a, you're not sure of the centric, which ideally should not happen, but sometimes patients keep shifting centric, a patient is medically very compromised, you're not sure, or it's a severe skeletal issue. In such cases, if you are going for what is it called? If you're going for monoplane teeth, it is fine. Don't the 0 degree generally kind of gives you an idea. I remember in Nair we had 0 degree teeth which had triangles in it. I don't know what it did except taking food, and it used to harden the food inside. So monoplane teeth are different from 0 degree teeth. They basically, the cuspal inclination is minimal to zero. But in majority of my cases, I feel that I don't even need to go towards monoplane, because if we make it absolutely flat, we don't have, how will the patient chew? So that is something which I would personally avoid until it is really, really necessary in any case. All right, so thank you, Dr. Prachi. Dr. Menon, can we have your mail ID to clarify any doubts? Yes. So I'll just a second. I'll just put my, I don't know where I've put, okay, so my mail ID, if you want to note it down, you can write to me in ADE Mumbai, that is ADE. I'll just write it down here for everyone in the chat box.
You can, yes.
So that it's easier. And also, if you can find me on Facebook, you can just put it on Messenger, because many times, if I'm being lazy, I don't read my emails. But if it's on Messenger, I'll see it. So if I don't immediately reply, because I get a lot of questions every day. So if I don't reply, don't feel that I'm not going to reply. My daughter's just 7 now. She's become 7 and she's become very demanding suddenly, but I will reply eventually. So if you can put it on Messenger, it is easier. If you feel that you're more comfortable because you're going to put photos or something and you're more comfortable with the email, I'm fine with this. I put the email here. There's another one, I'll put that also. This is my clinic email. So this, if I don't see, at least someone will see and tell me. So this is the other one. So you can connect with me here or on Messenger. I'm comfortable with both. And if I don't reply, I will reply, but it may not happen in one day. It may take 2-3 days or 4, but I will eventually reply. I always try to reply. Okay. Any other questions?
Nothing actually. Thank you, Dr. Shivangi. We have just an official vote of thanks for you. Okay, I just invite Dr. Binila for the vote of thanks.
Good evening, everyone. I, on behalf of the organizers and all the members of IDA Kochi, extend a very hearty gratitude to the speaker. Thank you, Dr. Shivangi, for gracing your beautiful work and sharing with us your valuable knowledge on this topic.
Thank you so much.
I would like to mention our deep sense of appreciation to the amazing audience for your active participation. Lastly, let me thank the office bearers of IDA Kochi, our President, Dr. Matthew Verghese, Honorary Secretary, Dr. Nevin Thomas, Treasurer, Dr. Nidhi Ravindran, and of course, our CD Chairperson, Dr. Brigida Manoj, for our enormous efforts in organizing such events for the members. Once again, thank you, Shivangi ma'am, and thank you all.
Thank you, Dr. Binila. Thank you, Dr. Shivangi, for the excellent presentation. It was a very, really great eye-opener. Thank you. And I'll just mention a few words like those who want YouTube link, will you please directly WhatsApp me, okay? So that I can send you. Anyway, I'll just send that into ID Kochi groups, but I don't know, some other ID members are there, like non-ID members also there. So those who want, actually, you can take my number. I think my number is there in the brochure. So that actually you can directly WhatsApp me. So I'll send the YouTube link. I'll send to you also, ma'am. So that actually you can send to your students or some, I think your group also.
Okay.
Okay.
Yeah, thank you.
Thank you. Okay, bye. Good night. Take care.
Thank you.